Namaskar friends, welcome to the video for vomitings in pregnancy. This is specially made for postgraduates and also for practicing clinicians. Now coming to vomitings in pregnancy, we have discussed basics in the previous video. You can get the link in the description box, or you can go through the playlist also. Now coming to the topic, approach to hyperemesis gravidarum. Approach to hyperemesis gravidarum, HG. Hyperemesis gravidarum. First of all, hyperemesis gravidarum occurs in around 0.3 to 2% of the pregnancies. In developed world, it is very less. Hyperemesis is nowadays very less, and the symptoms, they appear around 4 to 5 weeks of pregnancy, and they subside by around 14 to 16 weeks. They start on 4th to 5th week, means the first missed period, and they subside by 4 to 6 weeks, 14 to 16 weeks, and they are maximum between first missed period to second missed period. First missed to second, around second missed periods, they are maximum. The symptoms, they are maximum. So the woman usually comes with recent amenorrhea, history of amenorrhea to you, and tell you that she is having amenorrhea and she is also having the vomitings. Now, what in around 20% of women, this MSS gravidarum or this vomiting in pregnancy, they continue till term. This is important. It's not just the condition of first trimester only. In around 20% of the women, especially in those who had severe disease in the first trimester, in around 20%, it continue till term. The vomitings, they continue till term. Now, when a woman comes to you with history of vomitings, and if you on examination you find it is severe, what history are important? What negative history or what positive history they are important? It is either the past history of severe disease in previous pregnancies, or family history of vomiting, severe disease of vomiting in pregnancy in either mother or sister. Then having female offspring in this pregnancy, female offspring carrying female fetus inside is also important in cases of severe. It is around that 1.5 times the chances that she is carrying a female fetus if she is having severe vomitings in pregnancy, severe form of vomitings in pregnancy. Then trophoblastic disease, vesicular mole in this pregnancy because of increased HCG, multifetal gestation and carrying trisomy 21 in this fetus in this pregnancy because of increased HCG. So these are the histories that you are supposed to take. Then previous history of gastric ulcer or H. pylori infection. Previous history of diagnosed H. pylori or gastric. Similar symptoms in pre-pregnancy period also. So these are the history that you are going to ask. Now coming to what are the causes, what are the pathophysiology. So HCG is considered the most important hormone that is causing vomitings in pregnancy, and if it is higher, as we have seen in multifetal gestation or in vesicular mole or in hydrops and women carrying trisomy 21 fetus, this HCG is higher in amount, and so it is causing more symptoms, more severe form of this vomitings in pregnancy. So what are the pathophysiology? HCG is the most common, most preferred agent. It is in theory, there are the various theories. So HCG is the most preferred one which is said, because also when the HCG is at peak, that means then these symptoms are also at their peak at around 8 weeks. When it is at peak, the symptoms, they are also at peak. So HCG, in conditions where HCG is high, the symptoms, they are severe. So HCG is the most commonly proposed agent causing it. Now another thing, what is, it is said that TSH, there is, because it may be because of thyrotoxicosis. It is observed in, if you do the FT4 and TSH evaluation in a woman who has come to you with severe vomitings in pregnancy, what you find that TSH is low and FT4 is high. That means signs of thyrotoxicosis, but it is only biochemical thyrotoxicosis. Why? Because woman is euthyroid, there are no symptoms of thyroid, and also her pre-pregnancy levels, if they were tested, they were normal. So it is called biochemical thyrotoxicosis, which is seen in severe forms of vomitings in pregnancy, and it is nothing but because of the alpha subunit of HCG has similar structure as TSH. So the higher amount of HCG which is causing this severe forms of pregnancy, it stimulates the thyroid gland to give rise to FT4, and its negative feedback causes decrease in TSH. So it is only biochemical thyrotoxicosis, and clinically the woman is euthyroid. If you have doubt that whether she is really it is really thyrotoxicosis, then what other test are you going to perform? You will be checking the antibodies, thyroid peroxidase and anti-thyroid antibodies, to check whether it is some other form of thyrotoxicosis. If you have doubt, if clinically you have doubt whether she is really the case of thyrotoxicosis, then you may put her to those investigations. But usually biochemical thyrotoxicosis is seen when you evaluate the woman of severe forms of vomitings in pregnancy. So this is biochemical thyrotoxicosis you should be aware about in case of severe form hyperemesis gravidarum. Now there is another hormone, leptin, which is secreted from placenta. When we check for the levels of this leptin, it is in severe cases it is seen to be on a higher side. So it is also a causative agent, may be considered. Now what is the another mechanism? It is said that there is resetting of vestibular system in the inner ear. What does it cause? First of all, why this resetting of vestibular system in inner ear is happening? We have discussed in previous video of maternal adaptations in pregnancy that pregnancy is a state of hypervolemia, but osmolarity is reduced. Plasma osmolarity is reduced in pregnancy. So this plasma osmolarity is reduced as a normal. So vestibular system in the inner ear, it tries to adjust to this change in osmolarity, and then during this resetting it causes severe vomiting, and if it is not resetted timely, it may cause severe forms of vomiting in pregnancy. Why it is said? Because women those who have motion sickness, they are also more predisposed to severe forms of vomiting in pregnancy. So, those who are having this inner ear problem as motion sickness, they are more prone for this severe form of vomiting in pregnancy. So, this is another theory which is proposed, that there is resetting of the vestibular system, and also there is resetting because of this change in osmolarity. There is resetting of gastric emptying time. It also causes this severe form. So, these resetting, so you may say that the changes that are occurring in mother's body when she is pregnant, they are all, change in osmolarity, it causes resetting in other various system, and if it is not in time, what happens? It gives forms to severe forms of vomiting. Another proposed theory is H. pylori, concomitant H. pylori infection. This is a gram negative. We all know it is a gram negative spiral bacterium. Spiral bacteria H. pylori, and it is a causative agent of gastric ulcer disease. So, in that, if a woman is this H. pylori positive, she is more prone of having severe form of the disease, but this theory is not proved up till now in various studies. So, we do not have the confirmatory data, but it is proposed, and some studies they point that yes, it is causative agent, and some studies they do not find any correlation in the two, but it is for sure that it comes in one of the differential diagnosis. Also, in women who have severe form of the this vomiting in pregnancy, before next pregnancy, it is advisable, if they are H. pylori positive, you should treat the H. pylori by amoxicillin and concomitant proton pump inhibitor, and then she may ask to get pregnant next time. So, these are the causative agents, pathophysiology behind this hyperemesis gravidarum. Now, next coming to clinical presentation. She will come in OPD with or in emergency as vomitings, severe vomitings, not able to take anything. What are the criteria? If there is fall in weight of the woman by more than 5% of the pre-pregnancy weight, because of this vomitings, it is confirmatory that she is nothing but hyperemesis and she should be admitted. This more than 5% weight, this is important thing, and you should not ignore this. So, this is the importance of taking weight in cases in your history taking of this hyperemesis gravidarum. And if you know the pre-pregnancy weight, if the present weight is 5% less, then that means she is hyperemesis, you admit her. Then after admitting or after coming in contact with the patient, what are the further initial assessment that you are going to do? In your history, I just told you what negative and positive histories you are going to take, family history what you are going to take about the same disease in her sister or in her mother or in her previous pregnancies. Then you will ask about any history of gastric ulcer disease treated in past, okay, or symptoms pre-pregnancy also if she had the same symptoms, and what else about her weight gain. You will be assessing her whether there is weight gain or whether there is weight loss. If there is weight loss and if pre-pregnancy weight is available, or if she is coming to you, suppose initial visit when she missed her period, she came to you, you noted her weight, and after around 4 or 5 weeks she is again coming to you with severe form of vomiting, then you will assess whether this weight is increased or static or has fallen. So this is the importance of taking the weight. And you will ask her other symptoms like fever, like pain in abdomen, to rule out other causes of vomiting in pregnancy. Like if there is pain in abdomen, acute abdomen with the vomiting, then she likely, depending upon where the pain is present, she could be because of, it could be because of appendicitis, it could be because of cholecystitis, or it could be because of this acute pancreatitis. So all these concomitant history you will be asking. You may ask her about burning micturition in this pregnancy or frequency of micturition to rule out urinary tract infection. And it is also a differential diagnosis when a woman comes to you with severe forms of pregnancy. So you should not miss out all these things when you are taking case of this hyperemesis gravidarum, and or when a woman comes to you in clinics. So this was only about history and her physical examination. You will be also calculating the PUQE score. Don't miss this PUQE score. This is pregnancy unique quantification of emesis. So this is mother's risk. What it tells us is mother's risk. Mother's risk PUQE score. What is this? You should be aware about this if you are a postgraduate student. This score you will be obtaining when she is coming to you first contact. And also this PUQE score is taken when she is admitted, and you have to assess whether there is improvement or not. So what is this PUQE score? This is pregnancy unique quantification of emesis and nausea score. How it is done? We ask the woman what duration, about duration in hours, of nausea she had in past 12 hours. Then episodes of vomiting in past 13 hours and episodes of retching. Retching means dry vomiting, you can say. There is a strong feeling of that something will come out but doesn't fall. So episodes of retching in past 12 hours. This score you are going to ask. If she says there is no history, hours in duration of nausea, the score is 1. Minimum score is 1 in each case, and maximum score is 5. And in these two, and 3 is in these two. 5 in maximum score. Minimum score is 1 to 5, depending upon the, if there is no feeling of nausea, score is 1. There is no episode of vomiting, score is 1. If there is no episode of retching, then it is 1. If it is 1 hour duration of nausea, she says its score is 2. If it's more than 6 hours duration, the score is maximum 5. Similarly, if she has more than 6 vomitings, its score is more than 7 times vomiting, score is 5, and more than this 7 times retching, score is 5. So we can, and then we add up to assess the severity. So if it is 3, that means woman is asymptomatic. If it is 3, woman is asymptomatic. If it is 4 to 6, it is mild. And if the then 7 to score of 7 to 12 is moderate, and more than 13 or more than it is severe. So we first give the scoring on admission, and then we again ask her when she is admitted to assess whether the score is falling or it is rising. So it helps in assessing the severity and monitoring the response. So this PUQE is important to know. You should be aware about this, and if in your exam you do this, you tell about this, you will definitely going to impress the examiner. And also when you are in your wards, if you get a woman of hyperemesis gravidarum in ward admission, antenatal wards, you must write down this PUQE in your records. So it will give you knowledge and it will give you experience during your MD or DGO tenure, so that you will be able to learn this PUQE scoring in hyperemesis gravidarum. Now, what other test we are going to do in case of an other assessment when we admit or we come across the severe form? Then lab diagnosis. After admitting, after taking the history, negative, positive, every history, and after doing the examination to rule out other causes of vomitings, we will be discussing the differential diagnosis now in detail subsequently. What lab diagnosis are we going to send? We are going to send urine for ketones and chloride. Chloride is sometimes even absent in severe forms. So we are going to do a urine analysis, then electrolytes along with KFT and LFT. Electrolytes we are going to send, LFT, KFT we are going to send. Just now we learned about biochemical thyrotoxicosis, so we are going to send her FT4 and TSH level. We are going to send her amylase level also, sorry, lipase level also, to rule out the pancreatitis. And also these levels, they are sometimes seen to be higher side, and it is not because of the from pancreas they are secreted, instead they are secreted from the salivary gland, and it is the effect of severe form of vomiting and not the cause. So now let another thing, imaging. What imaging are you going to do? If you find that normal imaging you are going to subject is USG, obstetrics. This is to confirm the intrauterine pregnancy and to rule out vesicular mole. To confirm intrauterine pregnancy and to exclude vesicular mole, differential diagnosis. Also intrauterine pregnancy, whether it is singleton or multifetal. So you are getting all these data from the obstetrics. So you will be sending every woman for USG obstetric and also USG abdomen, whole abdomen. USG whole abdomen. This what is going to give us idea of cholecystitis, appendicitis, also her kidney status. So in cases of ureteric stone, what happens? There is acute pain in abdomen associated with vomiting. In that case, if there is hydronephrosis also, unilateral hydronephrosis, it gives indication that this is not hyperemesis gravidarum, but it is vomiting is associated with ureteric colic. So ultrasound examination, if you find on examination that there could be signs of obstruction, in history there is some that she is not able to pass flatus or stools, and on examination if you find that abdomen is distended, so in early pregnancy she is coming, you can subject her to plain X-ray abdomen erect, AP view erect, to rule out the intestinal obstruction. But it has to be done with the abdominal shield. Don't forget to put the shield over her pelvis. Now, if it is a severe form of pregnancy and she gives a history of blood in vomitus, especially in the after vomiting after having severe bout of vomiting if there is blood in her vomitus. So it may be because of Pylori V's tear of esophagus. So if there is a history of blood in vomitus, you may subject her to endoscopy to rule out this complication. And also simultaneously we will look whether there is any gastric ulcer disease or not. In that case, we will be subjecting her, we will be giving her treatment for same, that is amoxicillin along with proton pump inhibitor. We will be subject. Some women, they respond well to the gastric ulcer treatment. Now what next? What do we find? We have subjected her to various tests. In LFT, what can we get? We get bilirubin may be increased, but not to a very high level. Also, alkaline phosphatase may increase 2 times. Don't miss this. So if this is coming, it may be because of hyperemesis gravidarum only. Now in KFT, what can happen? In urine, what can happen? Specific gravity of urine is high because of hemoconcentration, and specific gravity is high in urine analysis. Ketones, if she is having ketoacidosis, ketones may be present. And what else? Chloride may be absent. So these are the findings you will be getting. Also on urine analysis, if you find pus cells present, then it is associated urinary tract infection, you treat it, and vomitings, they subside. So you rule out another differential diagnosis, that is urinary tract infection, by just simple urine routine microscopy examination. Now hyperamylasemia, amylase, if you check for amylase levels, I just told you amylase levels, what can you get? Increased levels of amylase, but it is a effect and not the cause. These amylase levels, they are secreted from salivary glands because of starvation. They are from salivary glands because of the starvation. This is the effect of severe form of vomiting, and this is not the cause. So you may get this increased amylase levels. Now what else? The thyrotoxicosis, biochemical thyrotoxicosis that we just saw, it usually subsides, the thyroid function test usually subsides, it comes to normal by 18 weeks gestation. Because we have seen that HCG, which mimics TSH, it starts falling after around 12 weeks. So at around 18 weeks, this TFT, which we got the biochemical thyrotoxicosis in investigating the hyperemesis gravidarum, it comes back to normal by 18 weeks. So if you get the deranged TFT in early pregnancy, in severe forms of vomiting in pregnancy, you are supposed to repeat the test at around 18 weeks whether to check whether they have come to normal or not. And if you have any doubt, then you will subject her to thyroid antibodies test to look for whether it is because of either Graves' disease or Hashimoto's thyroiditis, autoimmune. So you will be subjecting her to that if there is any doubt. Not every routine biochemical thyrotoxicosis woman should be put to this antibody investigation, but if this does not subside by 18 weeks, then yes, you should check whether this thyrotoxicosis that you are getting is not because of any other autoimmune disorder. So these are the investigation. Now coming to diagnosis. So the diagnosis of hyperemesis gravidarum is clinical. You clinically diagnose her that she is a case of vomitings, and lab finding, they are just helping you to know what the condition is and how it is responding. So it is the clinical diagnosis. No lab report is required to label a woman hyperemesis gravidarum. Diagnosis is clinical. Always remember this. Diagnosis is clinical. Now, then what are the differential diagnoses? What are the differential diagnoses of hyperemesis gravidarum? Now, genitourinary, I just told you UTI, you will be ruling out with the urine routine microscopy, pus cells, then uremia by doing KFT, and also there is a history of this kidney disease in her pre-pregnancy state also. Now, molar pregnancy. We did ultrasound obstetrics to rule out this molar pregnancy. Snowstorm appearance. Snowstorm appearance is present in USG in case of H mole, vesicular mole. Now, what next? Gastrointestinal is this H. pylori infection, gastric ulcer disease, gastric ulcer, gastroduodenal ulcer, then cholecystitis and appendicitis. Then what else? What other gastrointestinal diseases are the pancreatitis? So these are the differential diagnoses. Cholecystitis, appendicitis. Also there is a history, clear-cut history of pain in abdomen and vomiting and sometimes fever, which is this pain in abdomen, typical history. Acute abdomen is not present in a case of hyperemesis gravidarum. And in gastroduodenal, there is usually a history in pre-pregnancy state also. And if you have doubt, you can do breath test also for H. pylori infection. And if in still doubt, you can subject her to this gastroendoscopy. But it is rarely performed because mostly we get the diagnosis by other test only. Now, after this, what could be the endocrine? Addison's disease. But pregnancy is less likely and other features of Addison's disease are clinically evident in such cases. But it should be in your mind that what are the differential diagnoses. Also, hyperthyroidism, that biochemical thyrotoxicosis, vomiting is present. You have to differentiate this biochemical thyrotoxicosis from this hyperthyroidism. And I just told you, you will repeat it at around 18 weeks, and if you have doubt or if the values are if FT4 is too high, not marginally high but too high, or TSH is not marginally low but suppressed, then you will differentiate her as thyrotoxicosis. Then these are the endocrine things. Then diabetic ketoacidosis, in that case you will be having past history of diabetes. She must be taking insulin. If she is a very young primigravida, which is rare nowadays, but if she is very young primigravida, it may be that her pre-pregnancy this diabetes mellitus, usually type 1 she must be having, is missed, and she is around 18-19 years and she is a primigravida, this could be the cause. So you should you can do a urine analysis bedside, this glucose urine analysis at bedside to rule out this that she is not diabetic. Also, other causes, intracranial, if she is having this symptom of vomitings in previous, also she may be having her problem in her vision also. I told you should subject her to fundoscopy first to rule out papilledema, which may be because of this intracranial any lesion, and another is to rule out in severe cases the complications like retinal detachment and retinal complications. Now, vestibular disease, just I told you that women, those who are having motion sickness, they are more prone of getting this severe form of pregnancy. So, in that case also it is because of there is a pre-pregnancy history. So, that history in a woman with hyperemesis gravidarum, if you are getting this case, you in your history you always ask the past history of motion sickness. This is important. So, those women who are having motion sickness history, they are more prone for getting this severe form of vomitings in pregnancy, and rarely asthma, because of increased efforts in inhalation. More of the air is taken in the abdomen, stomach, and it causes vomiting. So, history of asthma, past history of asthma is also important in hyperemesis gravidarum or severe forms of vomitings. Now, what are the complications? Fortunately, in our era we have better antenatal care, we have early detection of pregnancy, we have early, more hospitalization in early form only, and so the grave complications that were seen in previous days, they are now very less, but you should be aware what are those. If it is untreated, then what can happen? Encephalopathy, okay, Wernicke's encephalopathy can happen to her, and Korsakoff psychosis, then subendocardial hemorrhages in her heart can be there, then she may land up in ARF also. So, these are the complications, and nowadays fortunately they are very rarely seen, but you should be aware about them. Now, if a woman is having severe form, there are some severe form of vomitings. There could be good news also associated with severe form of vomiting. What? These women, those who have severe form of vomiting, they are less likely to abort. They are less likely to abort. They are less likely to have preterm, and they are less likely to have stillbirth. So, maybe because if it is related with the HCG and progesterone, more of HCG, more progesterone, and less of the pregnancy complications like abortion, like preterm and stillbirth. So, these are the benefits women having severe form of vomitings in pregnancy. Also, this severe form, they are more commonly seen in young age. In young primigravidas, they are seen. In young primigravidas, if suppose her age is more than 30, she is less likely to have severe form of vomiting in pregnancy. This is important, importance of age in a woman of hyperemesis gravidarum in your history taking. If it is more common a disease of young primigravidas, and also if she is more than 30, she is less likely. Also, smoking history, if there is a smoking history, she is less likely to develop severe form of vomiting in pregnancy. So, these are the negative history important, age importance in case of hyperemesis gravidarum, and what are the benefit